Hey there, everyone. It is Kevin Henry, editor-in-chief for drbicuspid.com. Thank you so much for joining us for another episode of our podcast, and thrilled to be joined today by Dr. Safa Tahmasebi. Dr. Safa, how are you today?
Hi there, Kevin. How are you?
I am doing great. I really appreciate your time. Thank you so much.
Thank you for having me. I know you're a busy guy and taking time off to do this. I really appreciate it. Thank you so much.
Well, right back at you. I know this is time out of your schedule as well, but whenever I got the opportunity to talk to you about a very fascinating case, I wanted to jump on that chance. But before we dive into the case and before we talk a little bit about your thoughts on it, would you mind just introducing yourself to our audience quickly, and then we'll dive in?
Thank you, Kevin. Yes. So my name is Safa Tahmasebi. I am a prosthodontist by training. I did my bachelor's in biochemistry at St. John's University in New York. Soon after that, I moved up to Buffalo, New York to do my doctorate in dental science and a DDS degree at the University of Buffalo School of Dental Medicine. And soon after that, I moved down to the Bronx, New York, where I completed a GPR at the Albert Einstein University, Montefiore Albert Einstein Hospital. And then soon after that, I did my pros training at West Virginia University School of Dentistry. And then soon after that, I got paired up with a very competent oral maxillofacial surgeon who was practicing down in Dubai, the United Arab Emirates. And so I moved to Dubai, which was supposed to be just for a couple of years, ended up being a 5-year journey. And then I moved back to the United States back in 2019, where I joined Clear Choice Dental Implant Centers, and I became a director of a practice that pretty much specialized in full mouth implant reconstruction and full mouth implant rehabilitation. So that's pretty much my journey in a nutshell. And I'm a prosthodontist by training, but then because I've just been around so many sort of surgeons and surgical colleagues, I pretty much do both, and I enjoy doing both. And yeah, that's pretty much me in a nutshell.
It's a good nutshell and it's a good journey. And again,
Yeah.
I'm thankful you took a few minutes today because the case that we're going to talk about is fascinating to me. Again, for those of you watching this on drbicuspid.com, the images are in the article. So I want to make sure that you're seeing those while we're talking to Dr. Tahmasebi. If you're listening to this, we're going to have the link in the show notes so that you'll be able to find the article and be able to see the images as well. I'm curious, this gunshot wound that happened with this patient, what specific challenges were there that caused other providers to kind of back away or maybe turn the patient away? And what made you confident that this case was treatable?
Yeah. So this patient was a young man who I don't know the specific details of how the gunshot accident happened, but he was shot in the face at close range. And uh, I don't really also know the exact specifics of how his dentition was, but he had teeth. And when the trigger was pulled, he turned his face away, and the bullet's trajectory, and you'll see in the images that the trajectory went inside the oral cavity and ran across the maxillary frontal sinus and then exited right lateral to the orbit in the skin. So he was very lucky. He
Wow.
did tell me that in the emergency room, the treating doctors told him that the bullet bypassed his left orbits by less than 5-6 millimeters. So he's very lucky to have retained his eyeball on the left. And so that that apart from the aesthetic sort of complications that this presented, it also removed vital bone in the premaxillary area and including the frontal maxillary wall of the left sinus area right by the zygomatic buttress. Again, I don't know the specific details, but he did tell me that he had a sinus opening. He was very unconscious. He doesn't really remember much, but he does remember being repaired by the oral maxillofacial surgeons at the emergency room hospital. And when he woke up, they told him that he's going to need bone grafting, which may involve tibial or leg grafting, where they basically harvest bones from the iliac crest, from the hip, or they take it from the shin. And sometimes these grafts have to be vascularized so that they could basically stay alive. So it has to be a fibular flap. So when he was basically presented with all the augmentation and rehabilitation techniques that need to take place, he basically got scared. He did go after that to a few other clinicians, and they all told him pretty much the same thing, that your case is very complex, that we don't know what to do with this exit wound, with the bullet wound. And he also, I remember when he came to me, I specifically asked him, I said, did you see oral maxillofacial surgeons? And he said, yeah. I saw roughly about 7 or 8 different providers. Many of them were maxillofacial surgeons. And they all told me that my case was extreme. So yeah, and the reason why this case could be pretty much what's complex from a dental standpoint is because the sinus is a sterile environment, right? The sinus has to basically stay sterile between the oral cavity, and the sinus must not communicate. And so when this injury happened, his sinus was open to the oral cavity. And so when they repaired him, they were able to seal the sinus, but there was no bone in that area, particularly where the sinus sort of repair was performed. And so those are the reasons why this case was very challenging. And also it was on his CT scan, you pretty much don't see any bone in those areas.
Mhm.
And so that's the reason why this case.
So, what criteria did you use to determine the remaining bone volume was sufficient for implant placement? And what did you do about bone grafting or augmentation procedures?
So that's interesting. The way we approached his case, and I remember when I first met him, I told him, I say, I don't know if I can help you, but I'm certainly going to try. We took a CT scan that day, and I said to him, I remember telling him, I said, hey, come back and see me in a couple of weeks, and let me see, whether we can help you or not. So we took the CT scan that we had obtained from him that day. And, Kevin, today we are able to do things we couldn't do in the past. We can literally take someone's CT scan, which are made out of these DICOM files, and then we could put that in a software and convert those DICOM files to what we call STL files. And from those STL files, we can put that into a printer, and we can pretty much print someone's skull made out of a stereolithographic model, which is pretty much printed resin. And you could literally have someone's head or sinus anatomy in your hands. And so this technology is amazing, because just like how you and I discussed in the past, um, you know, when pilots take on new flights or new journeys, or let's say a pilot wants to start flying from New York to Sydney, Australia, they don't just get on a plane and fly away, right? They sit inside of something known as a stimulator, and then that stimulator stimulates the flight. It stimulates the altitude, the distance, or the takeoff, the touchdown and all that stuff. So they pretty much know the entire journey before they get on an actual plane. What this technology of being able to print somebody's jaw in an acrylic model is almost as if you're stimulating the surgery now, because instead of having to reflect the soft tissues and find bone, you actually know where the bone is. And this technology has really allowed us to be able to navigate ourselves in surgery and look for specific points where bone are there, where in the past, we used to perform what was known as exploratory surgery, where we actually pretty much used to open the flap, go in there and find viable bone, and pretty much guesswork or guess whether we could get fixation and anchorage or not. But because of this technology, we actually know how we're going to do it. It's almost as if you are sitting inside your car and you take your phone and you go to Google Maps and you put the coordinates and it tells you where to go. It's very much the same. From the minute you open the flap, you know the anatomical areas that you're looking for. You could literally actually have that plastic model sterilized, cold sterilized, and sitting on the patient's chest. And you could actually look at the model and then do what you have to do.
Wow.
And this technology is magnificent, because we didn't have this technology in the past. And this technology has really allowed us, like I said, to be able to navigate through the patient's anatomy without having to perform any guesswork, get in, get out. And because everything is sort of planned from before, the surgery time is reduced, the flap reflection is reduced, patients heal a lot faster. For example, I'll give you an example. You'll see in the images on the left lateral sinus wall, this entire sinus wall was missing. And so if we didn't know where this bullet hole location was specifically, in the past, you will just open a flap, and the minute you open the flap, you're inside the sinus. Well, because I knew where the location of the sinus entry was, I was able to actually perform something known as a split thickness flap, where you actually split the soft tissue, separate the soft tissue, and keep the soft tissue intact on top of the sinus and go around the defect and then reach the bone and then do a full bony reflection. And so, because of that knowledge, I knew exactly where that defect was. And once I reached it, I was able to split it, go around it, reach bone, and reflect it and not enter the sinus and allow the patient's soft tissue to keep the sinus separated from the oral cavity and then find the bone and place the implants and close it up. And we never got into this guy's sinus. So his sinus remained intact and untampered with. If we didn't know where this position, this location of the sinus exit wound was going to be, then the minute we opened the flap, we were going to be inside the sinus. Now, at this point, we would have to perform another procedure, and that is to close that sinus cavity. And that would have complicated things and would have compromised the integrity and the longevity of the dental implants. So this technology is available to us and it's cheap. It's very easy to do. Every surgeon, anybody that does complex full mouth implant rehabilitation, whether it's an accident wound like this, or it's a cancer case where there's a huge defect, or it's a normal case where you are just basically learning, or you're just basically starting your journey and you want to be better with anatomy, this technology is very available and all you need is your CT scan.
It's fascinating. It
Yeah,
absolutely is.
it really
So,
is.
can you walk us through the timeline from the time of initial consultation to the final restoration? How long did that take, and what were the key milestones for you along the way?
Yeah, so we first saw him. That's when I told him I could probably help him, but I didn't promise him anything. The next step was to bring him in and do an intraoral scan, right? So this is a iOS intraoral scanning where we scan the inside of the mouth to basically make him a provisional set of teeth to be able to be converted at the day of surgery. That day, I had the model with me. I sat down with him. I went through the model. I explained that to him. That happened 2 weeks after the initial time that I saw him. He agreed. And then from there, we went to surgery, which took maybe another couple of weeks. Once we performed the surgery, he had to heal for about 2 months. Osseointegration and the integration and the fusing of the bone with the dental implants roughly takes anything between 2 months to 2.5 months. So he was in a good set of temporaries for about 2.5 months. He came back and he was an amazing patient. You could tell that he was so excited and he had been following instructions. He knew that he has to make this work for him. And then I remember when he came in that day, I was actually performing surgery in the other room. My partner, prosthodontist, came into the room with a smile on her face. She's like, he's so happy. His implants are all fused with the bone. He's ready to go to his finals. And then we sent off his models. And then 3 weeks later, he got his permanent. So I would say probably the entire treatment took roughly anything between 2 to 3 months, maybe 3.5 months. And then you're probably anything between 6 to 7 visits total from beginning to.
Wow. We've talked a lot about the clinical and the technology aspects of this, but let's talk about the emotional aspects for just a minute. How did you manage those expectations? Because you said at the very start, you're going to try to help him. How did you manage those expectations along the way?
Yeah, we can do, we've reached a place and a time in our journey with full mouth implant rehabilitation that we pretty much can do some really highly sophisticated stuff. We can do fibular flaps. We can do significant graftings. We can do some really beautiful stuff with zygomatic implants and pterygoid implants and transnasal implants and transsinus implants. I mean, we really have come to a place where we can do anything, right? But none of that stuff can work if you don't have a patient that is committed. And none of that can work if you have a patient that doesn't have the commitment. And none of that can work if the patient doesn't come to their appointments. And none of that works if the patient doesn't maintain their prosthetics and performs a good hygiene. This patient did from the very start, from the time I met him in the consultation. You could tell this 6 foot, 250-pound ex-football player, young guy, the moment I walked into the room, he looked so small and demoralized and sort of decapitated emotionally from this procedure, from what had happened to him, that he looked embarrassed and he sort of looked at me with these puppy eyes. Can you help me, almost, sort of thing. When I saw that look on his face, I said, this is a guy who deserves help. This is a guy who needs it. Like you said in your question. I love what you said. How did you set the expectations? That's such a good thing to say. And that's what I did very early on. I said, there's a reason why other surgeons had turned you away. Those surgeons, I'm sure many of them are magnificent. I'm no different than them. So maybe I can help you either. And he looked at me. He said, you're the first person who has told me that. And you're the first person who has agreed to even look at my case. So if you can help me, great. If you cannot help me, there's no way I could be worse than where I am right now. When
Wow.
he said that to me, that's when I realized, okay, this is a guy who really needs our help. And then he was in an arch wire. So at the emergency room, I guess the bullet mobilized his teeth. And I think it was an altercation perhaps too. So his teeth were probably maybe mobilized and maybe in a bad shape. So they had placed an arch wire and he was in those arch wires for about 8 years. Arch wires are not supposed to be in there for more than a month or so. And so he was in a bad shape. So when he told me that, I was like, you know what? He's right. I can't leave him worse than where he is now. And so that sort of commodity or that interaction with him, setting the expectations from the start and him being involved in his treatment. And when I told him about, hey, listen, when we do this, you have to be on a soft diet. You need to clean the teeth. He's like, Doc, I'll do anything you tell me. I don't leave the house. I'm in a very bad shape in my life. I'll do whatever you tell me. You just tell me what I need to do and I'll do it. And so he was a very easy patient to work with. He was always nice to the staff. He was always so enthusiastic about his appointments. Every time he'd come in, he was joking around with everybody. He would joke around with me. So he made his treatment fun and he made his treatment very interactive. And so it was nice treating him for sure.
That's awesome. Last question for you. Obviously, this is an extraordinary case. I know you probably don't see anything like this regularly, but are there other types of complex cases where maybe a similar approach could be used or has been used by you?
Yeah, for sure. Just to kind of add something to the previous question, I do remember him saying to me that before he did this procedure, he was working from home, doing telemarketing, selling, I think, equipment. And when we treated him and he was finally done and he had his full set of teeth, I remember him saying to me, I asked him, I said, hey, how's this changed your life other than being able to eat and being able to speak better? And he said, because of this procedure, I actually don't work from home anymore. And I actually got a job at a retail store where I could sell my product inside of a store rather than having to do it from home. So the emotional impact is really significant for these patients. And for me, is one of the most rewarding things to be able to be involved in changing other people's lives is really the reason why I do what I do, or all of us do what we do. To answer your question regarding what other complex situations I have seen with these type of cases, of course, number one that comes into mind is cancer. Cancer can pretty much remove part of the jaw. And so those patients that have mandibulectomies or maxillectomies, those are really complex cases. And you have to work in a team approach with other sort of specialists and or maxillofacial surgeons that are involved in the treatment of oncology patients. The other set of complex situations that I see are patients that have big sinuses. Genetically, not all of us have the same sinuses. Some of us have very small sinuses. Some of us have very big sinuses. In fact, I have seen some patients with massive sinuses where the sinus scallops around the anatomy of the teeth, where the roots of the teeth are just basically poking inside the sinus. Those cases are the most complex because when those patients go to inexperienced clinicians that haven't had complex cases on their hands may look at a case, oh, let's remove the teeth and put implants in. And because this is such a transformative procedure, and because this procedure is becoming very routine, a lot of dentists are performing full mouth implant reconstruction, but they have not been trained to know what cases they should treat and what cases they should not treat and what cases they should refer to a specialist and maybe what cases we should not even remove the teeth. If you have a person who has a massive sinus and the sinuses are scalloping around their teeth and the patient is 75 years old, do not perform that procedure. Try to preserve their teeth. As a prosthodontist, we can make partials, we can make crowns, we can make bridges. Let's not basically edentulate these patients and turn them into a situation where the teeth had been extracted, implants could not be placed, sinuses are exposed now. There are multiple oral anterior communications where the sinus and the antrum is communicating with the oral cavity. We can't repair them. This patient is extremely atrophic, and now there is no room to do any normal dental implants, and these cases have to be turned into a advanced surgery like the one I just described. And even then, significant planning to be done, like what we described, by using CT scan, by using patients' models, by doing planning, maybe even working with other clinicians in a multidisciplinary approach. So those are the complex cases I see. And I always advise people that are getting into this procedure, not every procedure is the same. Not every patient is the same. Dental implants is not good for everybody. Do your planning, look at the patient's age, look at the patient's medical history, look at their anatomy, and decide whether you can treat this patient. And one last thing I would say about that is I always tell other clinicians that in dentistry and surgery, there's two sides. One side is the known side, right? This is Monday morning, you wake up, you go to work, it's a routine dental implant case, routine surgery. You do it while you're joking around with your staff, you're listening to Alexa, you're planning your day, and you work out that day, and everything is bubbly and nice, and it's a beautiful day, right? That is known the unknown. That is known as practicing in the known. However, sometimes with certain cases like the one that I described or the one that we are talking about today, that is the unknown. The unknown means that this is the dark side of dentistry, right? This is the cases where it's not a routine Monday morning. This is a case where before you go to bed at night, you're thinking about your surgery the next day, and you're saying that I need to know exactly what I'm doing. You need to have planned the case. You need to know how to perform the procedure. And so my advice to people who are getting into this procedure is always try to stay on the known. It's so much nicer to be in the known. It's better for you. It's better for your hair color. It's better for your bald spot. It's better for your psychology, for your heart, for your body, for your good being, for well-being. And every now and then, as you begin to get better, it's okay to kind of go in the unknown, poke your head inside the unknown, fix something small, and come back and go back in the known. And so to answer your question, yes, cases that patients that are at the borderline of becoming extremely atrophic, that are the borderline that you extract their teeth, there may be no bone left. Those are the cases that bother me the most, because I know that with proper planning and with proper diagnosis and with proper patient expectation and setting the expectations, and with the proper patient consultations, with the proper planning with other clinicians and other maxillofacial surgeons or colleagues, we can have better results. Those are the cases that bother me the most, because I know there were better alternatives rather than just take the teeth out and then realize there's no bone. And these patients go home in a denture. They suffer for months, particularly the older ones, and it's difficult to do surgery, advanced surgery on them. So those are the ones that I find the most difficult to treat and take care of.
Some great advice on what's been a fascinating case. And I
Yeah.
love the behind the scenes. But Dr. Safa, I so appreciate the time today. And I'm curious if people want to learn more, ask you questions, whatever that might be, what's a good way to get a hold of you?
Well, the best way to reach me is by Instagram. My Instagram name is drsafa.pros. So it's DRSAF as in Frank A.PROS. So drsafa.pros is the best way to reach me on Instagram. I post a lot of these advanced cases and surgeries on Instagram. So if you shoot me a question there, I'll get back to you right away. On another avenue of reaching out to me, courses and international and national continuing education that I perform for various type of institutes. The most popular institute that I teach for is the PICOS Institute down in the Tampa, Florida area. The PICOS Institute has been around for roughly about 40 years. In that institute, we teach everything from normal single dental implants all the way to advanced zygomatic implant rehabilitation and subperiosteal implants. At the PICOS Institute, we run a zygomatic training course once a year at a cadaver lab down in Tampa, where we spend about 4 days talking about anatomy, surgery, and then we take all that knowledge, including complications and management of complications with advanced surgery, and we take that into the cadaver lab. We actually perform that on actual cadaver heads, and participants really get to learn what we have learned over the past 40 years from our mistakes in zygomatic implant fixation and zygomatic implant rehabilitation. And in that institute, why I love being a part of that teaching facility is they teach the Zaga concept. You see, there's a concept for zygomatics that is called Zaga, and that stands for Zygomatic Anatomy Guided Approach. where you use the patient's anatomy to tell you the trajectory of your zygomatic implant. So if you want to learn more about Zygo approach or the Zygo protocol, and if you want to learn more about advanced surgery and zygomatic implant rehabilitation with other techniques such as transnasals and transinuses and pterygoid and subnasal implants, and particularly even newly palatal approach cases, then the Picos Institute where you could find me. And of course, I lecture across the world and in conferences, and would love to see you guys at the conferences. I always enjoy lecturing on the podium with other clinicians and also seeing friends and colleagues at these conferences. So that's where you could find me.
There we go. I know this will change a lot of viewpoints and a lot and spur some ideas from our readers and listeners. So I want to thank all of you for listening to this episode and watching this episode of the drbicuspid.com podcast. Fascinating way to think about a complex case and how it was handled and maybe what you could do when it's presented to you. Till next time, it's Kevin Henry, editor-in-chief for Dr. Bicuspid, signing off. And as always, wish you nothing but success.